Hi, and welcome to Level 5 Health and Social Care. We're looking at our final unit, Unit 505, working with people with complex needs. And for the first week, I want to talk about definitions of health, illness, and disability. We're going to have a little bit look at some of the historical factors as well about that. So, our objectives for this task will be 1.1 and 1.2. We'll be describing the historical and current definition applied to health, disability, and illness. And then you are going to choose one condition and you're going to analyse the differences in perceptions historically and in the present day. So you're going to be able to choose pretty much any condition that's been around for quite a long time. And I want you to do the research to find out, how that condition was dealt with before and how is it dealt with now, what's changed. Okay. You'll get some hints as we go along with some ideas. Okay, so let's sort of introduce the concepts first. Thinking about starting with the word health. The word health is derived from an Old English word for heal, hail, which means whole. And it sort of signals that health concerns the whole person, really. Although, strangely enough, the medical model doesn't always think like that, as you know, as we've discussed before. There are some common sense views of health which are passed on down through the generations, and it's our common cultural heritage. So we generally have a view of what the word health means. And there are two common meanings really that are in everyday use in most countries, really. One is negative, one is positive. The negative definition of health is sort of very straightforward. It's the absence of disease or illness. And this is the meaning of health that the Western scientific model or the medical model that relies on, really. And we'll probably talk about that a little bit further on. The more positive definition of health is a state of well-being. So it's sort of like the opposite, really. It's a sort of general state of well-being, and that's again interpreted by the World Health Organization in 1946 as part of its constitution as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So, in the World Health Organization's eyes, it's not just, the medical or the biological view that we're looking at, really. They were already in 1948 seeing health as a much bigger, rounder thing. But let's look into the Western scientific model because, to be fair, it's actually governed what we do and how we do it for a very long time, and some of you will already have experience of it, really. So this is the dominant professional view, and it's adopted by most healthcare workers, and it's tend to be the way people's training, both medical, nursing, therapies is pretty much the way the training and practice tends to be labelled. It uses this very narrow view, which is about no disease or no illness. So it's more by what it's not than what it is in that sense. And this view of health is really influential, mainly because it's been reinforced in training, particularly in that of doctors, consultants, um, and therefore, it's something that professionals are comfortable with and know about. And it also works within their field of ability as well, because it's about, fixing things, making people right. It sort of arose in Western Europe at the time of the Enlightenment. It goes back a long way, really. The rise of rationality and science as forms of knowledge. And previous to that, religion provided the explanation and understanding for what was going on, really. So if someone had what would be considered ill health pre-enlightenment, you would have got a priest in, really, or uh, to resolve problems, and it would have been, it would have been a sort of, is it as a spirit affecting you, or um, has they been influenced by the devil or things like that. So later on, as people became more scientifically aware with the Age of Enlightenment, that's hence the phrase the Age of Enlightenment, it substituted science for religion, and started to build activity based on sort of knowledge that people learn, and the pursuit of knowledge as well. And coming out of this, around this time, obviously, equipment and techniques for studying, particularly the human body, were being developed, like the microscope and the telescope. And observation, calculation, and classification was becoming a means. So, as a means of scientific investigation, experimentation was being developed, then health was being looked at in this way, really. And it was being put to fairly practical purposes. So if you sort of think, even if you think back to Leonardo da Vinci, those of you who may have seen any of his drawings and pictures, as well as a sort of famous artist, he was also an architect, but was a fantastic medical drawer as well, and also created scientific equipment, both designed and created scientific equipment, as well as helicopters and aeroplanes, but we won't even go there. But he's very involved at the time with the science of medicine. So this view of health really is characterized as being biomedical. So it's assuming that health is property of biological being. So it's your biological body, is healthy or not healthy. It's also by sociologists and psychologists considering to be a reductionist approach. So, the wide view of health and disease can actually be reduced to a small component of the biological body. So, my health really depends on the fact that my tummy is upset today. So, this huge health, humours, emotions, all goes down to the fact that I need my insulin, or I haven't had my antibiotic for my virus. So quite reductionist, really. It's mechanistic. It sort of looks at the body as a machine. So if something doesn't work, it needs fixing, really. But you tend to treat things separately. So in those days, if there was something wrong with my gut, they might sort of look at one area, but they might not look at what else might be affecting it. It was known as allopathic, sorry, which is working by a system of opposites. So if something was wrong with the body, then you bring in a treatment which applies the opposite force to correct the sickness. So, for example, if I'm a diabetic, it means that maybe my body is not creating insulin, not creating enough insulin. So, to treat that, I would give myself insulin, or that would be prescribed for me, and I would give the required amount of insulin, and therefore getting back on an even keel again. So it's creating the opposite. No insulin, give insulin, that sort of thing. It's pathogenic. It focuses on why people become ill. So it tries to find the root and the reason for it. What is the cause of it? And it's usually, in this view, it's usually, some part of the body that's failing or not working properly, or has caught an infection or a virus. It's also dualistic. It sort of believes that the mind and body can be treated as separate entities. So, when people are being treated in hospital, and the consultant comes from the sort of this medical model, really, they can often treat the mind separately. So they don't sort of think about how you're feeling about things. They might go, well, it's okay, well, here's a medicine. This will balance your insulin. So off you go. You should be fine now. Doesn't matter if you're emotionally upset about it. So It's a sort of an early balance, but we know that that has stayed with us and is still a bit of an issue in some hospitals. And finally, a health is predominantly viewed as the absence of disease, as we've said. So it sees health and disease linked, so that the more disease someone has, the further away they are from good health or normality. So, okay. So the less, the more or the less insulin that's being produced, the harder it is to get you balanced to normality. So moving on from the medical model, although this has stayed around and in some areas it still remains very, very strong, and I think that's important for you to remember. Although the social model is increasingly coming to the fore more, the medical model has never quite gone away, and there are some people who still adhere to it. Antonevsky called for a, a salutogenic approach, which looks instead at why do some people remain healthy? Instead of sort of working out why people are sick, it's like, okay, well, he's had the same problem as him. Why's he got through it really? And we look at this with people who've had various diseases where, say people have been exposed to a virus, which we all were during the COVID time. And some of us were exposed to the virus and recovered quite well, or didn't actually get sick at all. Um, and some of us were very unwell and unfortunately didn't recover. So Antonovsky would say, well, what is it about that person that got them to remain healthy? And he sort of looked at things like coping mechanisms, which means that some people can sort of rise above their illness sometimes, despite sort of adverse circumstances. He looked at the effect of change and stress and how that might enable you to be, give in to your or give in and suffer from your illness, or to rise above it if you're not very stressed or if you're not in a very difficult situation. So, so for him, Antonescu said an important factor was a sense of coherence, which had three aspects: understanding, managing, and making sense of change. So if the person had these abilities to understand their illness and to manage it, do the things that they were suggested to manage it and actually carry them out quite well, but also make sense of that change process that yes, they might not be feeling too good today, but maybe if they do all these things, they will feel better in time. These are all human abilities which you can nurture and develop as well. And Antonescu felt that people could develop themselves to actually manage illness better. So the medical model we know focuses on etiology, that's symptoms, and the belief that disease originates from very specific causes, usually something going wrong with the body or something failing or something infecting it. But we are aware now that the causes of some long-term chronic diseases in developed countries can often be social. It could be down to poverty. It could be down to people living in overcrowded conditions. And we need to sort of start taking these sort of things on board, really. So medical practices recognises that disease and the disease body, they do know that it needs to be put into the social context, really. However, although they have taken that on board, so they'll find out a bit about someone's background if someone's really unwell, if they're suffering from a disease that's normally eradicated. Is it because they're in an overcrowded position where they they're getting infected by other people, or is it because someone's brought it in from another country, those sorts of things? Or is it because their food or water is not clean enough or carries other infections that they end up with dysentery or cholera, those sorts of things? But it's actually because of their social conditions. And if they lived in a cleaner environment, with a smaller group of people in one little house, then they probably wouldn't suffer quite so badly from it. But nevertheless, even with the knowledge of the fact that the social context is relevant, and we know that because we look at it as part of our care planning process, the professional training of many healthcare workers still really exaggerates the benefits of treatment and doesn't really pay enough attention to prevention. So, not only have we, if you think back to those of us who've done health promotion, not only do we have to sort of spend time working on health promotion with the community, we sort of have to spend time on it working with the medics as well, because sometimes it's not a large part of their training either. They just come in and fix it. Some of them haven't been trained to make an attempt to prevent it, so that's something to consider. And this is because of the dominant concern of the biomedical model. So looking a bit further at the social model of health, which is sort of, come along alongside the medical. As I said, the medical model never quite goes away, but those of us who maybe not doctors may be able to pick up the social model a bit better. So if you can see from my little chart, the inner circle represents the individual dimensions of health. It starts off with physical, mental, emotional, social, spiritual, sexual. And this ties in a lot with some of you may have looked at Maslow's hierarchy of needs, the triangle. All of these areas are encompasses in Maslow's hierarchy of needs. If you're not sure about it, you might want to look it up and remind yourselves. Mental health refers to a positive sense of purpose, a feeling of belief in one's own worth, feeling good, feeling able to cope. Emotional health is about being able to make and sustain relationships, and feeling loved, basically. Social health concerns are about having the right support, having friends, having family, having members of the community to contact, doing other things, going out socially, whatever works for you. Spiritual health is being able to put into practice your moral or religious principles and the feeling of having a bit of a purpose in life. Now, for some people, that is of a higher level than others, depending on our background and our culture, but it is there and it does need to be considered. Sexual health is the acceptance and ability to be able to express your sexuality in the way that you want to. And then coming away from the humans, so as you can see, they are all little parts of the pie of the one person. But around that are the three wider circles. So they are stepping away. They're not just about that individual, but as you can imagine, are on a wider area. So societal health is about the links between health and the way the society that we live in is structured. So again, going back to Maslow's hierarchy of needs, the necessity for like shelter, safety, food, jobs, income, and how you're integrated in society, actually being an active part of society or not an active part of society. So there's a health level there really as well. So how healthy is society around you? How healthy is your role in society? And then an even bigger circle around that is environmental health. And that refers to the physical environment that's around you, the way you live, and in which other people live. Not just you, but the people around you, your family, your friends, your neighbours. And the importance of, this is about things like good quality housing, transport, ability to get to work, ability to get around the country. Sanitation, as I mentioned earlier, pure water facilities. So that's about keeping you alive as well, isn't it? Like we talked about earlier, clean water keeps you alive. So you need all those basics in place. And then you can sort of step up and think about caring for the community, maintaining a nice environment for the community around you, not just your family, but for the other people in the street that you live in, keeping it clean, keeping it tidy, not damaging people's property, caring for the planet, being sustainable, making sure that there will be there will be a planet for your children and your children's children. And the global value, the global health really is just bringing all those things together across the world. So the World Health Organization is probably the one organization that spends its whole life looking at global health. It looks at all the different countries where the weaknesses and the strengths are, and it looks at all these different levels of health within those countries, so it can have a view of the health of the planet really in all different ways. Here's a small chart showing you sort of the clear differences between the medical and the social model. As we have discussed these before in other units, but so health is the absence of disease under the medical model, but in the social model, it's a product of social, biological, environmental factors. Medical model, health services are geared towards treating the sick. The social model, there's a lot more emphasis on prevention as well as treatment, all sorts of stages of prevention. Medical model, high value is placed on specialist medical services. So, if you're a consultant neurologist, it'll be a very high value because you're a rarity, having things like MRI scanners. The social model, less emphasis placed on the role of specialists, but more attention to self-help and community activities. This is where we're talking about community self-help groups, community support groups, charities such as Age Concern, who do specialist work with older people, for example, Scope, who do specialist work for people with physical disabilities, those sorts of things, really. Medical model, health workers make a diagnosis and they treat and they sanction the sick role. If you remember, we've talked about the sick role before. They have the power to decide whether you are able to legally be sick or not. In the social model, health workers spend more time trying to enable people to take control over their own health, to manage their own health, and to make, to support you in not letting yourself get unwell in that sense, or intervening when you do feel unwell. Medical model is a pathogenic focus, which emphasizes finding a biological cause. So very much focused on biology. Again, I said, if your pancreas isn't functioning, you're not making insulin. You're not making insulin. You're diabetic. Whereas social model is a salatogenic focus, which is about understanding why some people are healthy. So why is he healthy? He's not. Both caught the same virus. Has he got coping mechanisms that he doesn't have? Okay, so it's you've got some comparisons there. Okay, so that was health. Now let's look at disease and illness. Disease derives from disease, which means uneasiness or discomfort. And nowadays, disease really implies a state of ill health, which should be verified by some accepted proof, really, generally by a doctor. In our society, as I've said before, the medical model still, is still lives strong, and very much the accepted proof of disease is usually the language of scientific medicine. So you're talking about blood tests. You're talking about X-rays. You're talking about using some sort of microscopic analysis, looking at people's cells, that sort of thing. Disease can be due to an exogenous cause, such as viral infection coming in from outside, like COVID, or an endogenous, something like inside the body. So here my example is an inadequate thyroid function. So some imbalance has happened within your body, or as I said, pancreas not making enough insulin for the diabetic. So health then is sort of the normal functioning of the body as a biological entity. So illness coming from that is a subjective experience of loss of health. So I'm not very well, so I feel ill. And this is couched in terms of symptoms. So if I've got aches and pains, I'm feeling lightheaded, I'm feeling dizzy, I've got a sore throat, then I'd hazard a guess I might have flu coming. So that's the loss of health. So I feel ill. So one way the illness is given meaning is sort of through the narratives about how we fall sick. Like, who gave me this? Oh, I was with that person, and I'm sure they were sneezing into a tissue. They probably made me ill. So why did they do it to me? Illness and disease are not the same, or there is quite a lot of coexistence. So, unfortunately, someone who may be diagnosed as having cancer through screening, so maybe through breast screening or something like that, they may not show any symptoms of illness. They may occur later on down the line, but at the time, they often don't show any symptoms of illness. So, that can be a problem. So, when someone reports symptoms, they need to take further investigations. So you can diagnose something even though there's no symptoms because the screenings come up. The difficulty is when you've not had the screening, of course, it's almost impossible to diagnose it until someone does get symptoms. And for something like cancer, that can be unfortunate. And that is why I mean it's really important to remind people, everybody that if there is screening available, both males and females, for different types of cancers, particularly, that you should go and take the opportunities to do it, because a lot of cancers do not have symptoms until they're much further down the line. If they're that much further down the line, sometimes they cannot be treated. So do remember that. Anyway, if someone reports symptoms, further investigation, such as my blood test, will prove that there is that disease there. So there, the two concepts of disease and illness coincide. And when this instance happens, when the two concepts coincide, we will probably more often use the term ill health. I have ill health. So it's sort of an umbrella term, and it just used to refer that experience of disease plus illness. So it's not being ill. Health is not being ill. It's the absence of symptoms. So how do social scientists view health and disease? Well, they see them as a social construct. They don't think they're just sitting around waiting to be investigated. They believe they're actively produced by ordinary people. Now, here's some ideas from a study. Cornwall did a study of London's EastEnders, and in this case, I've written EastEnders, but it's not the TV program. Okay, it's people who lived in the East End of London, and they sort of decided that through interviewing them and talking to them, they have three categories of health problems, and they looked at them slightly differently. They had something what they called normal illness, which is childhood infection, something that they assumed that everybody gets, like measles, chickenpox, those sorts of things, and that they didn't treat very seriously because it was common, everyone got them. Then they had things which they considered to be like real illness, which I suppose was probably another level of seriousness, where very often they were referring to things like cancer or leukemia or something like that, what they cast as a real illness, something seriously. Everything else was considered to be health problems, such as getting older, things not working quite so well because you were getting older, or things like allergies, certain things, maybe allergic to certain flowers and that. They just saw them as health problems. So that gave you three categories to work with, which was sort of quite interesting, really. And that was a sort of an accepted construct. However, Goffman really looked at how illness was sometimes considered deviance, so someone being different from the norm, and because of that, there was a source of stigma around it. And he sort of said there were sort of three sources of stigmas as well. Abominations of the body, which sounds very dramatic. It could be like, having nasty rashes, things that people don't like looking at, really. Like um, pussy spots and, sticky rashes and abominations of the body. I'm sure there are other worse things. I don't want to think about them at the moment. Blemishes of the character, which is an unusual one, but it's really what we're saying is, some sort of illness because of someone's behaviour. So originally, HIV and AIDS was considered a blemish of the character because it was something that was, in the early days was only caught by certain people, people who were homosexuals, people who were drug users. So they decided that was, it was considered a blemish of the character, really. Drug addiction, alcohol addiction would be considered blemishes of the character. So someone who's, not managing themselves very well. And the third source of stigma was a tribal stigma about race, nation, and religion. Maybe certain problems that were not considered acceptable in one culture that might be, not bothered about in another culture. So each culture has their own areas of stigma that I haven't mentioned under the other two, really. So, as I said, the subjective experience of feeling ill is not always matched by an objective diagnosis of disease. So, when this happens, doctors and health workers may label such sufferers as malingerers. Now, we've all had that at some time or another. Maybe, you've been wanting to get out of work and you've gone to the doctor and said, oh, I've got a pain. Oh, I feel this, I feel the other. And sometimes you're putting it on, and they know you're putting it on, and they either give it to you or they don't give it to you. But sometimes you actually do feel like that, but they don't see it if it's not an illness they know of. If your symptoms aren't adding up, and this is a real problem, um, sometimes they will think, well, you're just malingering, when in fact you do have an illness, but they don't know what it is. And this can have a really important consequence. It's like whether or not they will give you a certificate to get off work. And that could be, if a doctor feels that your sickness isn't genuine, they might not give you that certificate, which causes problems. You won't get paid. So there have been several conditions over the years that have suffered from this. Something known as chronic fatigue syndrome took years to be accepted as an actual illness. But most people thought that people just been a bit lazy, to be honest. Repetitive strain injury, RSI, where people usually gain through sort of working on keyboards for too long and having all sorts of really unpleasant pains. Now there's ways to work with them, like using splints and that. But you also have to limit the amount of time that you work on a computer and things like that. But for a long time, people are saying people saying, oh, I'm having these pains. Oh, you just don't want to do your work anymore and that. And one of the things that's come around most recently is long COVID. And I think it took a while for them to work it out. And now they're getting very much clearer. There is quite a complex illness called long COVID, which for people who usually had COVID quite badly, but recovered, but ended up with all this complex group of symptoms, which generally are known as long COVID. Long because you're sort of stuck with it for a long time. But they're different symptoms for different people. So that's been quite difficult to sort of prove and support. But it means that some people haven't been able to go back to work. Some people haven't been able to go to the shops. Some people's lives have changed very dramatically. Another example I've given you here is an example of homosexuals formerly considered to be sinners were labelled as ill, not bad but mad. So, I mean, I'm going back a long way now, probably before a lot of people who are reading this were born. But there was a time when it was considered to be an illness and they used to attempt to treat it. So, people were committed to mental institutions, hormonal treatments were given, and also for males, castration was given to deal with what was considered unwanted sexual behaviour, which is, people having affection for someone of the same sex. These treatments were mainly for homosexual men. I don't recall homosexual women having the same sort of level of treatments. They seem to be a lot harder on men. And this continued, into the 70s, if I recall, when finally the American Psychiatric Association redesigned homosexuality as non-pathological. So in other words, they said it's not an illness, it's just a way of being. Okay. So I'll just give you some time before we move on. If you can think of any other examples of a condition or a behaviour where its medicalisation has led to its acceptance or otherwise, So, or something that's gone the other way around that was medicalised but is now being considered to be a social problem or a social issue, or not a problem at all, actually, just a difference. Okay, so have a little think about that. You might want to use it as part of your explanations. Okay, well, let's start to think. So we're moving on really to look at disability. I'm going to go sort of quickly through the history of disability. There's a lot of articles written about it. I've given you a few articles to read in your resources anyway. But there's plenty of things you can read about the history of disability. So enjoy really. So if we go back to ancient civilizations, such as Greece and Rome, disability was associated with some sort of divine punishment or some sort of moral failing. So they decided that if you had a form of disability, you did something wrong and you were being punished for it. So in Greek mythology, for example, blindness was seen as a curse from the gods. So you obviously did something, or maybe your family did something and you were made blind. So because of that, people with disabilities are often marginalised and excluded from society. They're frequently viewed as inferior. I mean, you might have had a gabby leg and walk with a limp, but you're considered to be inferior to sort of whole people. Or in some societies, they're even considered to be dangerous and were not trusted or were locked up. Very often, in some cases, especially in ancient civilizations, people were abandoned or left to die. So it was basically a survival of the fittest sort of idea, especially if there's a physical deformity, because the general idea was that they wouldn't be able to look after themselves. Moving on to the Middle Ages, the perception of disability did shift a little bit. It was seen as a test of faith. So people with disabilities were often revered as saints or holy figures. That they'd carried their deformities, to show what good people they were. So it's a very different view, really. Well, that was in some communities. However, this view is often accompanied by a belief in the supernatural powers or magical powers. So there's the belief that sometimes people who were blind were oracles who could see into the future because they weren't hampered by eyesight. And they were often exploited for these abilities. And for example, people with dwarfism were often employed as jesters or court entertainers, and probably because they thought they looked cute, but also because every now and then, in all the plays you read about the Middle Ages, the jester tends to come out with some sort of profound statement. If you read Shakespeare, the fools or the jesters are frequently coming out with a sort of profound insight. So in the sense of being silly looking, but knowledge as well. In the Renaissance, there was a new era of humanism, and people were a bit more rational and scientific about understanding of a disability. with the development of medicine, people, are realizing, what was the cause of someone's blindness, what was the cause of their gammy leg, why did they limp? They found out about cerebral palsy. Um, so people started to study disability and try to find out much more about its causes and try to sort of create new technology to help, such as hearing aids and eyeglasses. They go back that far, really, to the Renaissance. So obviously in time, eyeglasses become something that was common for everybody. However, despite these advances and people being a bit more rational about disability, they still often stigmatized and excluded, mainly because I think it was just hard work, always sort of having to make allowances, always having to um, make things more accessible, really. So in that sense, again, the survival of the fittest thing was still strong, I think. Moving towards the Enlightenment, there was a major shift towards attitudes and disability. There was an acceptance that all individuals had inherent rights and freedoms that couldn't be taken away by the state or just couldn't be taken away because they were disabled. And this sort of led the way towards a much more modern concept of disability rights and led to the development of institutions and organisations to support and empower people. However, the institutions, were only as good as the people who worked there. I think you need to be aware of that. But the fact is, the idea was there was some sort of care and support was identified for people who needed it, whose families maybe couldn't manage it. The Industrial Revolution brought about really significant changes. People moving into the cities for work, really out from the rural agricultural areas into the cities where factories were being developed. Lots of new technologies created a lot of employment opportunities. And if people had limited physical disabilities, they would be able to take up these because so many people were needed to work in factories, and it wasn't very nice work anyway, generally. So with the growth of the urban centres, there was a development of specialised institutions for people with mental disabilities, mainly because they were in the city, whereas when they were in the country wandering about, they weren't bothering anybody. And when they came into the city, people were more aware of them, maybe, found them more offensive or found them more in the way, really. So you had positivity of the Industrial Revolution, with some people with more minor disabilities were able to maybe pick up work because they weren't strong enough to work rurally, but in some of the factory jobs they could. But also, particularly those with mental disabilities, very much were directed towards an institution, because if everybody in the family was at work, and in those days, right down to the young ones, people were at work, they were either at school or at work. There was no one there to look after them, to support them, and people were not happy with having them wandering around in society. So it was a huge development of quite large institutions, which I've put some pictures here for you. However, quite a lot of them were very poorly run, provided fairly inadequate care, and in fact led to quite a lot of abuse and neglect of people with disabilities, especially mental and learning disabilities. I thought you might quite like these pictures. This is a sort of Victorian institution that I think got knocked down in about 1990 something, but it's pretty old, and the picture from above, the drawing from above, actually comes from it as well, really, which gives you an idea. And you might be interested to know that this is actually the hospital that I trained as a nurse in. So I actually did my training in one of these. I'm a psychiatric nurse. I did my training in one of these lovely old Victorian institutions, which hadn't physically changed for a couple of 100 years, and we were having to sort of make do. It wasn't quite as bad as the picture above, I can assure you, but the building was the same. So there was a lot of locked doors, tiny windows. Those big windows, they're mostly hallways and day rooms, but the bedrooms. There was a lot of rooms that were a bit like cells as well, so you need to sort of know that. But it was hard work. There was an awful lot of people in these, and there was just like bodies everywhere, really. So it was quite hectic, but it is interesting anyway. So if you're interested, there's a lot you can read up about the history of some of the sort of classic mental institutions or asylums, particularly in the UK. There's been quite a few nice books written about it, some great pictures and that, which I took these two out of. But yes, I do remember the building when it was like that. And that top corridor, I worked on the ward, and I remember marching up and down it a lot of the day. So believe me, I know about it. Okay, moving on in history, the early 20th century, the eugenics movement gained popularity. I don't know if you've heard of the word eugenics, and people with disabilities were targeted for forced sterilization and even extermination. And obviously, one of the classic exponents was Hitler and the Nazi regime, where they did a lot of experimentation on people with disabilities. Because if you look at the poster, only healthy seeds must be sown. So there was a lot of forced sterilization for people who had like learning disabilities and physical disabilities. And yeah, I mean, Hitler certainly killed a lot of people that when he decided that they were going to sort of poison the purity of the Aryan race. Coming out of that, I mean, that was one of the things that, it started off, there was quite a few people interested in eugenics, until people started realizing what the end possibility of it was that if you don't look right, or if you've got green eyes and not blue eyes, maybe you could be sterilized as well. People started cracking on that, it wasn't too good and your human rights were not being considered. Coming out of that, the disability rights movement emerged in the 60s and 70s, sort of after the war, when when people found out some of these terrible things that had happened. The disability rights movement really emerged strongly, with activists demanding equal rights, access to education, employment, and public spaces, and an end to discrimination and stigmatization. And that's when, bringing in looking at sort of things like person-centered care, which we've talked about before, and nothing about me without me, those sorts of documents really coming in, making sure that people had a say in their own lives. So very, very strong pressure group organizations were really developed then for people with mental health, people with addiction problems, people with learning disabilities, people with physical disabilities. They've led us to where we are now, really. Again, with disability, we've got the two models. It's not really that different from any type of health. We've got the medical model, as we've discussed. It's a problem that needs to be fixed or cured. Sometimes people don't want to be fixed or cured, but that's the general belief, especially of the medics who are involved. It's focused on the person's impairment rather than, the effect of the environment and society around you. These are all the people who are involved. The impairment, if you look at the diagram, the impairment is the problem. So the disabled people here are passive receivers of services, which is either aimed at curing their problem, which very often can't be because it's that sort of disability, or managing that problem. And the medical model has been very much criticised for pathologizing disability and for ignoring the social environmental barriers. It's generally the social environmental barriers that exclude people with disabilities, not their actual disability itself. So let's look at the social model, and they've sort of turned it all around. As you can see, if you look at the diagram here, they see disabled people. They can be active fighters for equality, work in partnership with their allies. Remember, it's a bit like, again, looking at person-centered care, which we've done before. This is about working in partnership with the people who support you to actually, get the best life you can. So it's identifying what are the problems, what are the social problems that can be changed to enable that person to live their best life, really. So the structures in society are the problem. So things like an inaccessible environment. Somebody's in a wheelchair and they can't get into the library, because the doors don't work. These sort of things really, really important. Segregated services. They never go to a service or never join in with someone who doesn't have a disability because they've got a specialist service for people in wheelchairs. Again, why do we need that, really? Why can't they just be part of the whole? Think about how schools have changed. Instead of having lots of special schools, children are really in mainstream schools where they have to make sure that the doors and the ramps are there for people to get around, really. Inaccessible transport. How can people go anywhere if they can't even get on the bus? Okay. Inaccessible information. If you've got limited hearing, limited eyesight, what other ways can we provide information so that people can actually get to do things? So think about those sorts of things as well. It's a hugely different approach. It's just turning it around on its head, really. So the biopsychosocial model is also a model of disability which views disability as a complex interaction. So it's one of those, it sort of like brings the two models we've just discussed before together, really. According to this model, disability is not just a medical problem or a social problem, but it's actually a combination of both. And it emphasizes the need to address the biological, psychological, and social aspects of disability to improve the quality of life. So this is what our person-centered care tends to be built upon, really. There's a lot of issues. A biomedical model is about avoiding illness and not dying so quickly. Biopsychosocial model is about promoting health, improving the quality of life. Acts on risks. Other sectors of the community intervene, whereas the biomedical is only healthcare professionals intervene. Biopsychosocial model is transdiscipline. It goes across all boards, really. Teamwork is unavoidable. Diverse professional sectors and social participation are the base of the model, whereas in the biomedical model, diverse professional sectors, social participation is desirable, but we don't always manage to pull it off, really. So there is a little bit of a comparison. You can see how the biopsychosocial model is built on the biomedical model, built on the social model, and brought them together, ideally. Because when you're dealing with disability, you cannot ignore the medical part of it. If someone's disability can make them ill, but they can have problems with their disability that you may need to intervene, and it can cause them an issue. So we can't pretend it's not there. So otherwise we wouldn't be treating people properly. So it's brought the two together. Disability rights sort of steps on a little bit further even than that. Or I would say, most people say it runs hand in hand, I think. The disability rights model is disability as a human rights issue. According to this model, people with disabilities are entitled to the same human rights freedoms as everyone else, which most people would agree with. And its whole point is about removing discrimination and promoting equal rights for people, which is fine. In my view, I think that's a really important side by side, but I don't think it deals with everything. I think if you go back to the biopsychosocial model, I think you want that with disability rights attached, really, because just achieving people's rights on their own, whereas you don't you can, yeah, okay, you can give them the right to go on the bus, but if they can't get on the bus with a wheelchair, then all the rights in the world will get them nowhere. So there does need to be, some sort of balance. The cultural model, this is a fairly newer one. It's a perspective that disability is a cultural identity. This is something that's probably come out in the last, I don't know, 15, 20 years, really. But rather than a medical condition, or rather than someone's individual problem, and it identifies that people with disabilities have their own unique language, history, and traditions, which should be celebrated. So instead of being stigmatized because you've got cerebral palsy and you have a leg that doesn't work, or you move in a certain way, or you have some speech difficulties, it's just celebrated as, this is you, this is part of you. And maybe there may be a group of people with cerebral palsy who celebrate or who approach things in a different way. It's about understanding disability as a cultural identity, and just promoting acceptance and inclusion, really. But what is interesting is the cultural model sort of encourages people pride in their disability. Instead of being ashamed of their disability, they sort of say, well, I'm proud of being someone with cerebral, but I'm proud of being someone who's deaf. And they will frequently challenge negative stereotypes. And that's often down to the way things go at school, really, where they can, or if they get involved in some sort of organization. And it's treated as a form of diversity in the same way that other cultures, people coming from different countries or different cultures with different language, it's just treated as another cultural piece, cultural diversity. This is a picture of a guy who's really very funny. He's a comedian and he's got cerebral palsy. Um, I love his t-shirt. I'm only in it for the parking. And he often wears sort of slightly offensive, slightly t-shirts that you might find offensive, but he, as a member of the cerebral palsy community, does not. Um, and he makes a lot of jokes about himself that you would probably be nervous about making, but he sort of feels he can. And there are people in the deaf community like that as well. The deaf community is probably one of the oldest sort of cultural communities that seems to organise. I think they were one of the first um, diverse disability communities that really got very organised and developed a huge pride in being deaf, and sort of treated it almost like as a club that you're lucky to be a member of, in a way. It's quite interesting. So for private study, I'd like you to read a chapter in your resource links about health and illness. I've put this nice YouTube on for you about deaf culture, which I hope you would find interesting. And I want you to start thinking about your 1.2, where you have to choose a condition of your own. I've added an article for the history of mental health treatment. You can use mental health treatment. There's a lot of articles about the history of how that's changed. As I said, you can look back at the hospitals where I worked in for a start. You can choose any condition that has got some historical change in perception that you can find enough to write about, such as physical disabilities like cerebral palsy, learning disabilities, deafness. When you found something you're interested in, please contact me to discuss quickly to make sure it's okay. All right. Rather than you spend too much time on it, just contact me and say, I'm looking at the history of, people with hearing issues. I'm looking at the history of people with cerebral palsy or people with learning disabilities. Okay. And if you, again, usual thing, if you have any questions, you can WhatsApp me. Okay, great. I'll see you in week 2. Thank you.